And we'll talk about treatment and prevention. So how do you treat and prevent malnutrition? This is just a picture from an organization in the UK showing a wasted child. And then she still looks pretty small here, but you can see she finally has cheeks. She looks healthier. She's not pale. And she's got a little bit of subcutaneous fat. So this is kind of a nice before and after picture. And going back to this same slide, now we'll focus on intervention. So all these kind of lightning bolts, where in this kind of vicious cycle can you intervene to prevent malnutrition from continuing? So you can treat infection with antimicrobials, you can help repair the gut with micronutrients, give an adequate diet, maybe probiotics, we don't really know, for kind of better microflora, and fix water sanitation issues, give vaccines in terms of preventing further infections. And from an even more macro public health perspective, kind of you have social protection, you have to look at every sphere: agriculture, poverty and development and poverty reduction, inequality reduction, education, women's empowerment, and the health system. You really need a multi-sectoral approach to impact health on a population level. And I'm not sure how many of you are going into kind of more public health versus clinical fields. So key public health interventions: infection control, hygiene, immunization, dietary diversification, promoting and supporting breastfeeding, supplementation with single or multiple micronutrients. We'll talk about multiple micronutrients, especially fortification of stable foods, and home fortification. So then you get into politics where, you know, this has to be done right in a multi-sectoral way. This is an article about a food distribution program in India, which was basically seen as a political scheme and not sustainable. This is an Economist article, but basically saying that giving this plan to give out a lot of rice and wheat was not, you know, it was very expensive and wasn't getting to the right people and wasn't sustainable and wasn't addressing the systems issues that we just talked about. So it's really important to kind of think about how this is being done. Evidence-based interventions that do work. So again, we talked about breastfeeding, complementary feeding, supplementation of vitamin A and zinc, and I'll go through all of these a little bit more. And appropriate management of severe acute malnutrition, because when you have a child with severe malnutrition in front of you, you're not talking about systems issue at that point. You really need to address the patient in front of you. So in terms of breaking the cycle, talk about starting with maternal undernutrition, with prenatal micronutrient supplementation, which decreases small for gestational age status by 9%. Enough energy and protein decreases small babies by 31%. And iron supplementation reduces low birth weight by 20%. So nutritional interventions along with family planning activities to support women can break this kind of intergenerational cycle of growth failure. Breastfeeding is really important short term. It's helpful for nutrition, immunity, growth, and development. It reduces morbidity, mortality, and hospital admissions due to diarrhea and respiratory tract infections, and prevents atopic diseases. It reduces the risk of sudden infant death syndrome. Long term, it may protect against obesity later. It may protect against atopic disease and type 2 diabetes among adolescents, and maybe it affects IQ. The evidence for that is a little bit less strong. Complementary feeding is also really important. So it influences growth, development, and health. It's really important in helping children explore different tastes and develop food preferences, and it helps set the infant's threshold for sweet and salty tastes later in life if they're given appropriate complementary foods. And you know, I used to think it's really a resource issue if families, you know, where I practiced, especially in Central America as well as here, if family has access to the right food, then this should be easy. And certainly access is the first barrier, but they're also showing studies, even in low resource settings, that education around complementary feeding does make a difference as well. So it's a combination of resources and education. The role of protein content is really interesting. Clearly, you need enough protein. You don't want too much protein because you end up with effects on insulin releasing amino acids, IGF-1, and it really affects weight gain in the first 0 to 24 months and adaptogenic activity. So high protein intake may actually increase risk of obesity, even though in the kids we're seeing with malnutrition, we're actually tend to be more worried about low protein intake and things like kwashiorkor and edema. So in terms of each individual micronutrient, you can see they all impact public health outcomes. Vitamin A supplementation results in 23% reduction in under 5 mortality rate and 70% reduction in childhood blindness. Iodine supplementation affects IQ significantly. 13 points is a big difference from a public health perspective. Iron results in 20% reduction in maternal mortality. Zinc, 6% reduction in mortality, but 27% reduction in diarrhea. And folate reduces neural tube defects like spina bifida by 50%. So what are the solutions? This is from the Copenhagen Consensus Center from 2008. It's a little old, but it's still relevant. So micronutrient supplements for kids, micronutrient fortification, expanded immunization as well when we talk about infection, biofortification, deworming so that kids can actually absorb the nutrients they're given, and community-based nutrition promotion, as well as kind of all the other non-highlighted items there that play into these things. It's really all interconnected. These nutrition interventions are very cost effective. So micronutrient powders in dollars, it's only $2 per person per year, but the benefit to cost ratio is huge. It's 37 to 1. It's interesting to look from a public perspective on what gets funded. So even though nutrition is such a major player in morbidity, mortality, there's much less investment than in funding for HIV/AIDS, which is also very important, but it's interesting to look at why there's such a disparity there, and I think it comes down to politics and advocacy, and the fact that these malnourished kids are not advocating for themselves. So what is and then this is what a lot of what I do clinically, so I'm happy to talk about this in more detail, but and this is something that health promoters can do really well, or health workers. What is the experience of feeding like? Is there aversion? What is the parent-child or caregiver-child interaction like when it comes to feeding? And things I tend to ask is, what is behavior like? What are meal times like? Who provides meals? What is the setting? Is there modeling? What distractions are used? Actually, where I practice, there's a lot of use of distraction with screens like smartphones and computers and TVs to try to get kids to eat when they don't want to eat. How are new foods introduced? Is there forced feeding? Are kids self-feeding? What kind of utensils are used? Are there punishments for not eating? Are there rewards for eating? And I always look for signs of aspiration because I think we tend to miss it a lot. So like a problem with airway protection, either due to neurologic issue or an anatomic problem like a laryngeal cleft, where things are, especially liquid is ending up in the respiratory tract, and that's causing aversion or difficulty feeding, especially in kids with neurologic issues or prematurity. We see a lot of coercive feeding, and it can be tricky to ask about this, but it can exacerbate the problem, and it's a catch-22 because it's a child who's malnourished, so that the caregiver or parent desperately wants to get nutrition into the child, but it ends up leading into worse and worse kind of interaction and worse nutrition as the child refuses more and more because it becomes a negative experience. So we do a lot of work in terms of response to child's hunger and satiety, and trying to, as we're addressing the nutritional issues, also trying to focus on making the feeding experience positive. Diarrhea management is also really important. This is a place where we lose a lot of nutrition and lose a lot of ground. So children with diarrhea should first be assessed according to standard kind of WHO plans, treated for dehydration. Oral rehydration therapy is the first line of treatment, but I'm not sure what practices where you are. I'm really interested. Breastfeeding should be continued throughout the rehydration process. Here in the US, we tend to give a lot of Pedialyte or ORS and stop breastfeeding, and that's not actually the right thing to do. We want to keep breastfeeding and continue to feed with nutrient-dense foods and actually add oil and things like that rather than give kind of the brat diet, which, you know, the typical diet here is bananas, rice, apples, and toast. We're trying to fight that and say, no, you want to keep giving like really high quality nutrition, even through the diarrhea. So here's kind of harmful practices that we're seeing in diarrhea, according to one of a public health article from 2015. Inappropriate medication use, like antimicrobials, anti-motility medicines, fluid restriction rather than giving more fluid, food restriction rather than giving more food, and restriction of and breastfeeding. And this leads to more treatment failure, nutritional deficiency, and mortality. Rotavirus is also really important in terms of a public health intervention to decrease diarrhea. Rotaviruses are responsible for about 50% of diarrheal episodes in the world. So diarrhea should be addressed with vaccination efforts, along with oral rehydration solutions, zinc supplementation, and the public health interventions like water, sanitation, and hygiene, like we talked about.